systems in the abdomen. So we're going to go over the imaging clues to detect the source of bleeding, because this is important, as you all know. If we can pinpoint the source of bleeding, which is not, always commonly done, it's great help for our clinical colleagues to guide treatment and triage the patient. So I'm going to also emphasize the importance of CT first, because it's the workhorse imaging modality in ED, emergency department for these patients. I'm going to also talk about MR in diagnosis and treatment planning of these patients. So general overview, as I said, it's not really common. By definition, spontaneous intra-abdominal bleeding, abdominal bleeding, may be defined as the presence of intra-abdominal hemorrhage from a non-traumatic and non-iatrogenic cause. So there's not going to be any surgical intervention and no history of trauma. Then we call these intra-abdominal bleeds as spontaneous intra-abdominal hemorrhage. So liver, spleen, adrenal glands, kidneys, vascular structures, you name it. Every organ system in the abdomen may be affected and may all be considered, should all be considered actually, among the sources of the hemorrhage. So the clinical presentation is mostly non-specific. Patients present with abdominal pain. The pain can be vague or severe. It's really highly variable, and it's really not really dependent on the size of the hemorrhage as well. So imaging is crucial because all sorts of intra-abdominal pathologies, including diverticulitis, appendicitis, mesenteric ischemia, they may all mimic the presentation of clinical presentation of intra-abdominal hemorrhages. So CT findings, I want to highlight the CT findings because it's the workhorse modality in ED, as you all know. It's kind of a stethoscope now, right? I'm sure it's the same in your hospitals too. The emergency physicians, the surgeons, the trauma, all types of surgeons, they are so reliant on CT for diagnosing acute intra-abdominal conditions and triage the patient accordingly, whether to surgery or conservative treatment. So the CT findings depend on the age of the hematoma, whether it's acute, subacute, or chronic, and location. Acute hemorrhage typically measures 30 to 45 Hounsfield units on pre-contrast unenhanced images. High protein content is believed to be the cause of this high attenuation, relatively high attenuation. So when it gets clotted, the blood gets clotted, it appears more hyperdense. The Hounsfield units goes beyond the level of 60 as the concentration of the hemoglobin increases. Geographic areas of high attenuation surrounded by areas of lower attenuation is kind of somewhat typical for subacute bleeds. So let's start with the visceral causes and the liver, the largest intra-abdominal solid organ, right? The king of the abdominal cavity. So let's start with the liver. And let's start with neoplastic causes. So this patient has known HCC. He was undergoing chemotherapy for his unresectable disease. And, several months after the diagnosis, he presented to ED with acute onset severe abdominal pain. So on the screen, you can see a large mass in the liver. This is the portal venous phase. You don't see the typical arterial enhancement here. There's a large lesion here, as you can all see, and there's perihepatic fluid here in the peritoneal cavity, and there's fat surrounding in the adjacent preperitoneal fat planes as well. On the coronal images, you can see again the huge mass and fluid in both right and left paracolic gutters, as well as in the pelvis. So this is a typical finding of HCC. This is the most commonly bleeding tumor in the liver, which undergoes a spontaneous hemorrhage. So anytime you see a mass, bleeding mass in the liver, you should always consider HCC, no matter the history of the patient is. So in the kids, hepatoblastomas, you all know, are the most common primary liver tumors, more than HCC in the pediatric population. So this patient has no known disease, presented to the ED with severe abdominal pain and mild hypotension. The ultrasound scan, our resident, the on-call resident performed the scan, saw a large mass in the liver with air fluid levels. So the patient was referred to MRI, contrast MRI, and On pre-contrast T1 image, you can see the hypointense lesion in the right liver lobe, and there is hyperattenuating area, which may be suggestive of hematoma, right? A hemorrhagic component here. On T2, you can better appreciate the debris, the serum, and the fluid level here in different parts of this tumor. Heterogeneous contrast enhancement. You saw in a pediatric patient with no known history of malignancy, a large tumor in the liver is almost always conclusive for hepatoblastoma. So this patient was later underwent biopsy after medical treatment, and hepatoblastoma was confirmed. So adenomas are relatively rare in adult population. By definition, classically, it's seen in, like young women who are having contraceptive pills. Contraceptive pills are not always used for contraception, as you all know. For hormonal regulations, contraceptive pills can also be used. So this is a young lady with a long history of contraception, oral contraceptive use for polycystic ovary syndrome, presented to ED with, again, severe right upper quadrant pain, acute onset, no known history of any malignancy or anything. Again, the primary ultrasound examination. We use ultrasound very commonly in Turkey as a diagnostic tool. Well, in US, it's relatively rare, uncommon. But in Turkey, we use it a lot because the MDs, the radiologists, are doing the scans. So she saw a large mass in the liver. So adenoma was obviously considered, right, in a young woman, has a history of contraceptive use. So an MRI was performed. On the MRI, on T1 weighted image, you can see the pre-contrast image, hypoattenuating lesion mostly, but there are hyperintense areas within this mass suggestive of hemorrhagic component. So mostly hypointense, so hyperintense areas suggestive of hemorrhagic components. So on T2, heterogeneous signal intensity, some hyperintense areas with hypointense areas, but the hyperintense areas on T1 appears to be somewhat hyperintense on T2 weighted images as well. So adenoma was confirmed on biopsy, and the patient underwent conservative treatment, and the contraceptive pill use was terminated. And like around 15 months after the initial presentation, you can see the regression of the primary tumor with minimal residual hemorrhagic component. This is the follow-up CT, which confirms the regression of the tumor after the cessation of the contraceptive use. So metastatic disease, the most common liver tumor is obviously metastases, around 40 times more common than the primary liver tumors. So this patient is, again, pediatric population, known rhabdomyosarcoma, metastatic rhabdomyosarcoma to the liver, was undergoing chemotherapy, known liver mets, presented to ED with severe abdominal pain, right upper quadrant pain. CT, pre-contrast CT, you can see hypoattenuating metastatic foci in the liver parenchyma. But here on the lateral side, on the right lateral side of the liver, you cannot really see the continuity of the liver contours and the continuity of the liver capsule. So on post-contrast images, coronary formatted image, you can see this large lesion here is the source of the bleed, because you cannot see the continuity of the liver contour here, and there's a lot of free fluid, which is obviously hemorrhagic in nature. On the right side of the on the right side of the abdomen, in the right paracolic gutter, in the pelvis, and on the left paracolic gutter. So metastatic diseases can also be the source of spontaneous hemorrhages in patients with a history of malignancy, known or unknown. So you always have to take into account the possibility of a metastatic disease in the liver. So another patient, this is an adult patient, 57-year-old male with known jejunal adenocarcinoma, known metastatic liver disease, undergoing chemotherapy, presented to ED again, same clinical scenario, diffuse abdominal pain, mostly in the right upper quadrant, no metastatic disease, so immediately underwent ultrasound MRI examination. Pre-contrast T1, you can see large metastatic disease in the liver parenchyma, mostly hypoattenuating peripherally, but centrally, mostly hypointense peripherally. And in the central part of these tumors, you can see hyperintense, T1 hyperintense areas, more prominent in the posterior one. On T2 weighted images, the hyperintense areas appear to be hypointense, likely due to a hemorrhagic component. The hypointensity is less in the anterior one. So, these images confirm acute intratumoral hemorrhage. There is no intraperitoneal hemorrhage. The hemorrhage is intratumoral. So this patient is more lucky, right, compared to the previous ones, because the hemorrhage is intratumoral. The pain is real and should be treated, but it's likely going to cause life-threatening hemorrhage because of the confinement of the metastatic disease in the liver parenchyma. So the liver parenchyma basically serves as a tamponade to prevent the extension of the bleeding here. So, non-neoplastic liver diseases may also cause spontaneous hemorrhages. We can also see them. So this patient, young patient, no known disease, presented to ED with abdominal pain, which got worse over the last 24 hours. Ultrasound, the co-resident saw a large mass, heterogeneous mass, solid mass, in the right liver lobe with minimal perihepatic fluid. So the patient underwent a CT scan, contrast-enhanced CT scan. Here you can see a large hypoattenuating mass here in the right liver lobe. And you cannot see the continuity of the, liver contour here. And this mass extends beyond the confines of the liver parenchyma. And there is mild perihepatic fluid, as you see on axial and coronal images. You can better appreciate the discontinuity of the liver parenchyma here. This is where the tumor ruptured. So this was a cyst. So how we understood that was an MRI, obviously. It looks like a solid mass on CT. So we did an MRI as well to characterize more this focal lesion. So on T2 weighted image, you can see it's mostly hypointense, but there are bright areas as well in the periphery. On T1 pre-contrast, there's hyperintensity around the tumor. You can see it here. On post-contrast subtraction images, you don't really see any enhancement. There's some mild enhancement, maybe peripherally. So this turned out to be a cyst. The patient was insistent on being operated. So underwent surgery. So pathology confirmed no tumor. This was just a biliary cyst which bled spontaneously. So again, cirrhosis may be counted as among the non-neoplastic cause of spontaneous hemorrhages. Obviously, when you see a cirrhotic patient with bleed, you should always consider HCC, right? Because HCC is much more common in these patients. But cirrhosis itself, without HCC, may also be a predisposing disease for spontaneous liver hemorrhage. So in this patient, known cirrhosis, no HCC, normal AFP, serum AFP levels, presented to ED, again with abdominal pain, not that severe, but it got worse in the last week. So he decided to come to ED for pain. On ultrasound, the consultant radiologist did the ultrasound. This was a daytime and did not see any mass, but he saw some subcapsular fluid. So he was concerned about hemorrhage, but didn't see a mass, so referred the patient for an MRI. On MRI, pre-contrast MRI, you can see the liver, it's obvious, the cirrhotic, right? The caudate lip appears slightly prominent, the liver contours are irregular, there's posterior hepatic notch sign. So this is typical chronic parenchymal liver disease. But the area of concern here in subcapsular area is T1 hyperintense on pre-contrast images. There's another T1 hyperintensity here, it's more nodular, right? So we have to be more vigilant on this one to rule out an HCC. On T2 weighted images, these areas are bright, and we did not see any abnormal enhancement here. So we made a decision of subcapsular hemorrhage, and they regressed on the follow-up study. So let's move on to the spleen. So spleen is the second largest solid organ in the abdomen, and it's a very common source of bleeding in trauma, right? It's the most common source of solid organ source in traumatic patients with intra-abdominal hemorrhages and bleeds. So this patient has a history of chronic pancreatitis, alcohol abuse, presented to ED with severe abdominal pain, more prominent in the epigastric region and the left upper quadrant. So CT scan was done. That was the initial study here. We didn't do ultrasound. So you can see a large hypoattenuating fluid density subcapsular area in the spleen, which is significantly compressing the splenic parenchyma. On the axial plane image, you can see a small hypodense linear area. Like it's very similar to a laceration that we always see and that we commonly see in trauma patients. And you see the layering here, right? In the posterior aspect of the subcapsular fluid area, there's hyperattenuating areas, and the rest is more hypoattenuating. And there's another slightly hyperattenuating area close to the spleen. So this patient is splenic vein occlusion, increased pressure, venous pressure, increased blood pressure in the spleen, spontaneous laceration, and subcapsular hematoma. The patient underwent immediate surgery because he or she, I don't really remember, he was severely hypotensive. He was severely hypotensive, and the surgery confirmed intraparenchymal laceration with large subcapsular hematoma. Um, that's it. So chronic warfarin use, so anticoagulation use, antiaggregant use is very common in modern medical practice, right? For all sorts of cardiac diseases, vascular diseases, or stroke patients, it's very commonly used. They're mostly safe, but they're not that innocent. So this patient was on chronic warfarin use, presented to ED with severe abdominal hemorrhages. By the way, all patients are our patients. There's nothing from the literature. All patients are from our archive and from our publications. So this patient has chronic warfarin use, presented to ED with severe pain, abdominal pain, acute pain. So you can see on the CT, again, a similar large subcapsular hematoma. Splenic parenchyma is compressed. In this patient, you can also appreciate the active contrast extravasation here. So this patient has active bleeding in the splenic parenchyma. You can better appreciate it on the portal venous phase. This is the arterial phase. It's smaller, but on portal venous phase, it gets larger and larger. So this patient, again, underwent emergency surgery, which confirmed the findings. So this was an enigmatic case. You know, we really didn't decide before the surgery what's really going on here. This patient, no known history of any malignancy, presented to ED with abdominal pain. So ultrasound confirmed subcapsular fluid and heterogeneous area in the splenic parenchyma. So here is the MRI. On T2 weighted image, you can see a slightly hyperattenuating area in the anterior aspect of the spleen, and there's a large subcapsular fluid, likely consistent with a hematoma. You can see it's crescent shape, it's T2 hyperintense, fluid intensity. So pre-contrast, there are some hyperattenuating area, hyper intense areas, right, on the peripheral part of this mass and also inside this mass. And T1 hyperintensity here in the subcapsular hematoma is mostly suggestive of hemorrhagic elements. Sorry. You know, post-contrast didn't reveal anything. So the patient underwent surgery because a malignant process could not be definitely ruled out based on imaging. Although, you know, you really don't consider angiosarcoma here because primary angiosarcomas are rare, in 1 in 1 million, as far as I know. And at the time of diagnosis, they're mostly metastatic, right? They're highly aggressive, biologically really aggressive. But we really couldn't rule out a lymphoma or some other malignancies. So this patient underwent surgery, and the pathology did not find any malignant cells in the splenic parenchyma. And this finding was confirmed to be an epithelial cyst, which spontaneously bled. So I want to show you a different patient, sickle cell anemia. It's very common in my part, in my country, because we are a Mediterranean country, and in the Mediterranean basin, sickle cell is really common. I don't know the situation in India, but it's really common here. So we see a lot of patients with sickle cell anemia. So this patient has known sickle cell anemia, come to the ED with severe abdominal pain. On the CT, so obviously sickle cell crisis was the initial diagnosis. So the patient underwent a CT scan. On coronary formatted image of the arterial phase. You can see a large non-enhancing area in the spleen with some fluid in the subcapsular area. There's a small area of enhancing splenic parenchyma. So the kidneys don't look very fine, right? So they're also hyperperfusing, it looks like. On the axial plane image, you can see the viable splenic parenchyma and large areas of non-viable infarctus splenic parenchyma. So this patient has acute sickle cell crisis with some subcapsular hemorrhage, but mostly it's an infarct. So you should always consider subcapsular hemorrhages and infarcts who present to ED with severe abdominal pain, sickle cell crisis. That should be the leading diagnosis in a patients with known sickle cell anemia. So let's move on to the urinary system. So the kidneys, they are the leading organs in the urinary system, and hemorrhagic lesions and hematuria are very common, right, in the kidneys and the bladder, the urinary system, to say the least. So this patient has no known history of any malignancy, presented to urology clinic, not to the ED, with hematuria, with gross hematuria, clotted with clots. So obviously we did the CT urography. On pre-contrast image, you see slightly distended left renal pelvis with hyperdense material. So this is really concerning for hemorrhagic fluid, right? Hemorrhagic content in the renal pelvis. So the right kidney appears completely normal. So on post-contrast coronal image, you can see a relatively hyper-enhancing mass here, which extends into the papillary system, the kidney papilla. So what happened was there's a mass here which bled into the renal pelvis and presented to the clinic with hematuria. So the surgeon resected this tumor, which turned out to be a papillary RCC. So obviously, urinary bladder tumors, enlarged prostate gland, these are the most common etiologies of hematuria, gross hematuria, but we should always consider renal tumors or renal causes in patients with hematuria as well. So, angiomyolipomas, they're notorious for spontaneous bleeds, especially when they are larger than 4 centimeter. So this patient has no known disease, no history, presented to ED with severe abdominal pain and acute clotted hematuria. So on the left kidney, you really can't appreciate the left kidney as well. I think this is the area where the kidney is, or maybe this, who knows, right? So we gave contrast, and this is the enhancing liver parenchyma. There's a large pseudoaneurysm here, and there are, as you can appreciate, there are some macroscopic fat densities. So this is very, very suggestive of a bleeding angiomyolipoma, right? So we did an angiography, and we embolized the source, and the patient was treated. This is the post finding. This is the enhancing pseudoaneurysm, and this is the post-embolization finding. There's no contrast filling. So renal cysts, they can also bleed, just like the liver cysts. So always consider about that. So this patient, again, presented to the urology clinic with mild, vague left flank pain and hematuria. Hematuria was leading finding. So on ultrasound, we saw a large mass. It was not a cyst, but there was no flow on color Doppler examination. So we did an MRI. So on MRI, on pre-contrast T1, you see hyperattenuating, mostly hyperintense. Sorry about that. Mostly hyperintense T1 hyperintense lesion with suggestion of papillary areas in the wall and hypointense areas. So we gave contrast. Not very helpful, right? Because you are looking for a bright thing in a bright area on T1. So we did a subtraction. There's nothing, no enhancing areas within this structure. But the patient and the surgeon was somewhat, patient was really nervous about that. So the surgeon did a partial nephrectomy, which confirmed this lesion as a cyst, which bled, and there was no neoplastic element on the pathologic spaceman. So not all renal hemorrhages are neoplastic, right? There are non-neoplastic causes as well, again, related to anticoagulation. So this patient was on chronic anticoagulation treatment for cardiac valvular problem, presented to the urology clinic, not much pain, but severe hematuria. So obviously the patient was referred for a CT urography. And on the pre-contrast image, you can see distended right renal pelvis with hyperdense material. I hope you can all see my arrow and cursor on the screen. The other kidney appears unremarkable. So we injected contrast. What you see is, you see the pelvic wall, the renal pelvic wall, is thickened with hypoattenuating and hyperenhancing areas. And this is the renal pelvis cavity. It's somewhat obliterated. So this is typical for renal pelvic wall hemorrhages, especially in a patient with a history of anticoagulation use. But you should definitely do a vigorous follow-up to rule out a renal pelvic tumor in these patients. But given the history and the findings, this was found to be consistent with anticoagulation-related hemorrhage, and the patient responded well to supportive treatment. Oh, and the other finding in this, this is a different patient, so not the same patient. This is a different patient, again, anticoagulation-related hemorrhage in the kidneys. But I want to show this in that patient. You have to always pay attention to the other organs as well in patients who are on anticoagulation. This patient also presented with significant bleeding per rectum, hematochezia, and the CT confirmed thickened walls, which is very typical for bowel wall hemorrhages in patients with anticoagulation used. So always look at the other organs as well. So rheumatologic problems should also be considered in the underlying etiologies of spontaneous renal hemorrhages. This patient has a long-standing lupus. It's well known and under treatment. Presented to, and also had a renal transplant because you see the graft kidney in the right iliac fossa because of chronic kidney failure. Presented to ED with significant flank pain. So the patient underwent a CT scan. You know, you see large retroperitoneal soft tissue attenuation lesion, likely hematoma, and you see the native kidney here. We injected contrast, and when you inject contrast, you can see the active extravasation here. So the patient underwent first for embolization, but you know the embolization, there was no source. You know, the angiography could not delineate a source for embolization, and the patient underwent surgery. So the surgeon took out the native kidney with the large hematoma, which confirmed the non-neoplastic nature of this finding. You see, they saw this on the angio, but they were not really sure whether this is the source or not. So the patient had to undergo surgery. So the urinary bladder. So urinary bladder, always think about the urinary bladder when you see a patient with hematuria. So this patient presented to the clinic, the urology clinic, with hematuria, gross hematuria. You know, you see a large mass in the urinary bladder, but is this all the mass or there's some hematoma in it? Because you have to say there's hematoma in it, right? Because that changed the triage of these patients by the urologists. So we injected contrast. This is the enhancing part. This part appears to be the tumor, and the other non-enhancing part appears to be the hematoma in the urinary bladder lumen. Again, Plavix-related large mass. You know, it's tough to differentiate this from a tumor on this phase, but you know, on the urographic phase, you can see there is no connection of this large mass with the urinary bladder wall. So this is most likely consistent with a hematoma and not a neoplastic process. And the cystoscopy confirmed this finding. So let's move on to the adrenal glands. So adrenal glands are not among the common sources of spontaneous intra-abdominal hemorrhages, but they should always be considered. In contrast to other organ systems in the abdomen, when you see a hemorrhagic structure or hemorrhagic focus in the adrenal glands, you should always consider a neoplasm first, you know, especially adrenocortical carcinomas. Adrenocortical carcinomas, as you all know, are rare, not very common tumors, but they can be really fatal. I mean, they can be really grave. They can have really great prognosis. So early diagnosis is really critical. This patient, young patient, has no known history of any disease, presented to ED with severe abdominal pain and flank pain. CT scan showed a large hemorrhagic mass in the adrenal gland location. And there are some enhancing areas you can see within the large hematoma. So the surgeons, surgeons did a surgery on this patient, which confirmed adrenocortical carcinoma. So pheochromocytomas are relatively rare primary tumors. This patient presented to the emergency department with abdominal pain and flank pain. So ultrasound confirmed a large mass in the adrenal gland region here. And this is the Doppler examination. So on CT, you can better appreciate the mass. There are some enhancing areas. Non-enhancing areas are more abundant than the enhancing areas. And there is like increased density, hemorrhagic densities around this mass. And this is a delayed phase. So surgeons did surgery, obviously operated this patient, which confirmed spontaneously bled hemorrhagic pheochromocytoma. So primary tumors should always be considered, or neoplasms, secondary neoplasms should always be considered differential diagnosed in these patients. So this patient is, I think, around early 50s, known cirrhosis, known HCC. Here you can see the CT scan. You can see the infiltrating lesion, HCC, pathologically proven HCC in the left liver lobe. There's tumor thrombus in the portal vein as well. But you can also easily appreciate the metastatic disease in the adrenal gland. So 2 weeks later than this scan, the patient came to the ED with severe abdominal and flank pain. What you see here is that small tumor bled, right? There are a lot of like fluid in the hepatorenal fossa. You can see a large hematoma, active contrast extravasation. The tumor is there. So, HCCs tend to bleed spontaneously in the liver, and their metastases also do the same. They can bleed spontaneously when they are located outside the liver. So this is a good example of spontaneously bleeding adrenal gland metastatic disease. So RCCs, they are the most commonly metastasizing tumors to the adrenal glands after the lung tumors. This patient has a history of RCC, which was treated with nephrectomy, left nephrectomy. So he was under remission and presented to the emergency department with severe abdominal pain. CT scan showed a large hemorrhagic area in the right adrenal region, adrenal gland region, some enhancing areas or active contrast extravasation, stuff to differentiate. On the arterial phase, you can again see. So you always have to look at the arterial phase images if you have to see if there's any active contrast extravasation. So these areas constitute active contrast extravasation areas because they are not here. So the surgeon did a surgery, emergency surgery, the urologist did emergency surgery, and they took out this hematoma and cleared the area. Pathologic examination confirmed metastatic RCC, which spontaneously bled in the right adrenal gland. So pancreas, right? Pancreas, it's really rare, honestly speaking. I only saw a few tumors which spontaneously bled in the pancreas. This is one of them. So this patient didn't present to ED, came to the general surgery clinic with abdominal pain, which started around a week ago. It's not horrible, but it's really annoying to the patient. So we did an ultrasound first, and we saw a mass in the pancreas. So we sent the patient to the MRI, emergent MRI, to rule out a pancreatic mass. So what we saw here on T1, you see a hyperintense area in the pancreatic head. Relatively hyperintense. It's not really hyperintense, but there's some hyperintense areas here, but slightly hyperintense compared to the pancreatic parenchyma. On T2, you see the lesion is hyperintense, hypointense. It's heterogeneous in terms of signal intensity. There's some peripancreatic infiltration. The adjacent pancreatic parenchyma is somewhat edematous. So whether this is, there's a mass here, right? It's a cystic, looks like a cystic mass which bled, but it's tough to say. On post-contrast, you can see the nodular enhancement in the wall, and there's wall enhancement. So you should consider two things, I think, in this patient. Honestly, I've never seen a spontaneously bleeding adenocarcinoma of the pancreatic tumor. So you should consider two things, I think. One, spontaneously bleeding neuroendocrine tumor, or a cystic pancreatic lesion which bled. So the surgeons operated on this patient, and this turned out to be a cystic neuroendocrine tumor. So the central part is mostly necrotic with hemorrhagic component, and the peripheral part is the viable tumor component. So this is again a crazy patient. Obviously we didn't diagnose this as an endometrioma at the first glance. So it's a young woman presented to the ED with abdominal pain. On CT, we saw a large cystic mass in the pancreatic tail with a thick enhancing wall. On MRI, you can better appreciate the cystic nature, but there's fluid around the spleen. You can see it in both CT and MRI. There's likely hemorrhagic, because there's T2 hypointense areas around the spleen. So obviously, we first thought about a mucinous adenocarcinoma or a mucinous pancreatic tumor, neoplastic process in the pancreatic tail, which bled. Surgeon did an operation on this patient, which turned out to be an endometrioma, which bled. This is very rare. Actually, this is the first case that I saw. So always think about, or also it's not a very common thing, obviously a very rare thing. Only anecdotal case reports are there in the literature. Always think about the endometrioma as well in the differential diagnosis in a fertile age woman. So this is the other patient, again, similar patient. You can see a cystic lesion, which turned out to be an endometrioma. I didn't go into details, this one. So gastrointestinal tract, tubular structures in the abdomen, the hollow viscus, is a common source of bleeding, right? And most of these bleedings are not neoplastic, but always think about neoplastic tumors of the small or large bowel loops when you see a patient with hemophagocytia, depending on the age as well. So this patient has no known disease, presented to ED with severe hemophagocytia, which caused hypotension. That was that severe. The episode was that severe. Emergency CT scan, there's active contrast extravasation from the thickened sigmoid colon and proximal rectum. You can clearly see it. So this finding is highly suggestive of a colonic tumor, right? Which is bleeding. You can see the active contrast extravasation here. Patient underwent an immediate angiography. You can see active contrast extravasation from the IMA branch, which was successfully embolized, and the patient was later operated by the surgeons, which confirmed the colonic tumor. So think about the non-neoplastic bleeding as well, both from the small and large bowel loops. So angioectasia, it's tough to diagnose clinically. And also from imaging standpoint, it's tough to diagnose. But you have to be really diligent while looking at the, especially the arterial phase images of CT. So on the arterial phase image, coronary format, in one of the jejunal loops here, proximal jejunal loops, you can see it's like ectatic areas, enhancing areas, and they do not change in configuration on the portal venous phase. So always look at the portal venous phase when you see something like this, because if they change configuration on the portal venous phase, you should always consider an active bleeding. But here, the configuration was stable in both arterial and portal venous phases. So we were concerned about angioectasia, small bowel angioectasia, which was confirmed on the angiography examination. You can see like irregular chaotic vascularization here in the small bowel loop. So the finding was confirmed on the angiography. So non-neoplastic bleeding should always, again, be taken into account when you see a patient with spontaneous gastrointestinal bleeds, hematochezia. Always check the history. You should always be in close contact with the referring physicians to check if the patient is using any medications that makes them prone to spontaneous bleeds. So this patient has a history of warfarin use, not very diligent on the use, and the INR was around 9 or 10 when she presented to the ED with spontaneous, severe hematochezia. On the CT, you can see thickened wall, which is highly suggestive of a mural hematoma, and also severe stranding and vascular congestion in the adjacent mesentery. Obviously, this finding is non-specific, right? You can see this finding in patients with vasculitis, in patients with focal mesenteric ischemia, Behçet's disease or other rheumatologic diseases. But in a patient with anticoagulation use always consider spontaneous mural hemorrhages as well. So let's move on to the gynecologic causes. Let's start with the neoplastic causes first. So this patient presented to ED with severe hematochezia, known endometrial cancer, which was inoperable. So on CT, you can see a large pseudoaneurysm from the internal iliac branch, which fistulized into the rectum, adjacent rectum, and caused this active bleeding. The bleeding was so severe that the patient was immediately taken to the angiography suite right after the scan. And that was treated with a covered stent into the internal iliac artery, which excluded these large pseudoaneurysm because the tumor eroded the internal iliac artery, causing this pseudoaneurysm. The pseudoaneurysm was excluded with the covered stent, and the patient was treated. This is the angiography imaging, which confirms the pseudoaneurysm, large pseudoaneurysm here. So young women, severe pelvic pain, right? Like ovarian cyst rupture is a very common diagnosis. We always see it in the ED all the time. Here, you can see a young woman with known ovarian cysts and endometriomas. This is the pre-event MR scan, presented to ED a few days after with severe pelvic pain. On the CT image, you can hardly see these cysts, but there's a large high-density fluid in cul-de-sac, right? This is very concerning for hemoperitoneum, hemorrhagic components in the intraperitoneal fluid. And if you look closely, you can barely appreciate the serum and fluid level here in one of those cysts. So this is an ovarian cyst rupture, spontaneous bleed. Again, this is spontaneous bleed into the cul-de-sac. Always check for the signs of active contrast extravasation. Sometimes you can see them. So if you see something suggestive of active contrast extravasation, always relay that message to the referring physicians, and always get a delayed scan. If you can wait for 2-3 more minutes and rescan the patient's pelvis. If you see any change in the configuration of the area of suspicion, then you should always consider the active contrast extravasation, because when you detected active contrast extravasation, that may dramatically change the patient triage and management. So finally, I want to talk about the non-visceral bleeds in the abdomen, spontaneous bleeds. So intramuscular hematomas, you all know they're really common in the anterior abdominal wall, in the psoas muscle or iliopsoas muscle. It's relatively common. So this patient was on anticoagulation, presented to ED with abdominal pain. It's a deep abdominal pain. It was blunt, but severe. So on the CT scan, you see this is the normal right psoas muscle, asymmetrically enlarged, heterogeneous left psoas muscle. And there is an active blush here, right? This finding is suggestive of active contrast extravasation. Not all active contrast extravasations are arterial. So venous bleeds may also cause contrast extravasation. So don't jump to the diagnosis that, this is always arterial. Always consider venous origin as well, especially in intramuscular hematomas. So this patient underwent angiography, did not reveal any active contrast extravasation. The patient was treated conservatively. So abdominal wall, that's the most common site of intramuscular hematomas in the abdomen. So again, anticoagulation use, you can see a large mass, it's a lenticular shaped, the shape of the psoas sheath, the rectus sheath, the rectus abdominis muscle sheath, and you can see the serum and the sediment level. When you see this level, serum sediment level or fluid, serum level, it's mostly more predictable, I should say, for a subacute phenomenon, not an acute phenomenon. That's not always the case. But when you see this serum sediment level, always consider a subacute process, not an active one. So this is a young woman, not presented to the ED, but went to the general surgery department for pain, focal pain in the anterior abdominal wall. So we did an ultrasound, and ultrasound showed a mass here in the anterior abdominal wall, irregularly shaped. It's nasty looking, right? It's hypointense nodular contours, so it's kind of nasty. There's not much vascularity in it. We did an MRI. An MRI, you see a bright T1 hyperintense dot here, which is suggestive of a hemorrhagic component. It's in the rectus abdominis muscle on the left. Heterogeneous enhancement. It looks nasty, but in a young fertile age woman, especially who underwent a cesarean section before, always consider the possibility of a rectus muscle endometrioma. That was our presumptive diagnosis in this patient, which was confirmed after surgery. So this is an example of a neoplastic bleeding in the retroperitoneum. So this patient presented to the ED with acute abdominal pain. It was deep, blunt, but severe enough to seek medical attention. On the CT, we saw a heterogeneous mass. It's well-defined borders, right? It's not aggressive. It's not going anywhere. It's just there, adjacent to the left psoas muscle. On the coronal image, you can see we're not really sure if there's any enhancing component or not. So this patient was operated by the surgeons, and this lesion turned out to be a schwannoma, which demonstrated intratumoral bleed. So the key here is, in the posterior perirenal space, fat here, you see this stranding. So this is highly suggestive of focal hemorrhage / inflammation. You can better appreciate that area on the coronally formatted images inferior to the level of the tumoral mass. So I'm going to conclude my talk here. Hopefully you're still there and not bored. So my take-home points is, first, spontaneous intraabdominal hemorrhages are not common, but they're not uncommon. They're not rare. They're not anecdotal. So always keep it in your differential diagnosis list when you look at an acute abdomen. So clinical history is key. Always be in close contact with your referring physicians. Always ask for any history of anticoagulation use. Always ask for any history of hematologic problems. Always be in close contact with them. Because sometimes they didn't even know that the patient has sickle cell disease, as was the case in our patient. So always ask them if the patient has any history of disease, so they can get deeper with the clinical history. So correct protocoling is essential. So if you are concerned, it doesn't really depend on the request of the referring physicians. Always get the initiative, grasp the initiative, and think about the patient's history and presentation. If you think there is a suggestion, there's a possibility of hemorrhage, always do a multiphasic exam. Get pre-contrast images, always. So you can better appreciate if there's any active bleeding or not, other than just, trying to figure out whether there's bleeding or not after the patient was scanned. So the other thing, always search for the underlying neoplastic process. Even if you don't see the mass, always consider this possibility in your mind. And if the patient is stable, the surgeons are not very willing to operate, or the patient was not willing for an operation, always recommend a follow-up scan, maybe like a 4 weeks, 6 days. It's arbitrary, I know, but always recommend a follow-up scan and confirm that the lesion is getting smaller and you don't see any enhancing components. So always search for an underlying process, underlying neoplastic process, until proven otherwise. So use IV contrast whenever possible. Try not to get any non-contrast only scans in these patients. Again, as I said, always do a follow-up imaging to confirm resolution. So these are the suggested readings that I might recommend. Hopefully you can find them useful for your practice. Thank you so much for your patience and your attention.